Hello, everyone. Thank you for joining us today for our webinar on a guide to the longitudinal family physician payment model. Today, we will explain the new payment model in detail, sharing insights on how it affects family physicians and show how we can help you decide the potential next steps for your practice. Just a quick note, Dr. Care is not affiliated with Doctors of BC and BC Family Docs. Our work is separate and independent of their nonprofit organization. We are sharing an update of the new payment as defined by the ministry and providing insights on how we may be able to help. So let me start off by just introducing myself. My name is Daniel Brenner, and I'm the product manager at Dr. Care. Dr. Care is the largest provider of billing and practice support for over 2,500 physicians across Canada. On average, we have helped doctors recover $25,000 to $30,000 of revenue per year. And our solutions and services are designed to help doctors ensure that they are maximizing the revenue, improving patient care, and growing their practice. Just some webinar logistics before we get fully into it. All attendees are in listen-only mode. We are recording this webinar, so it will be available to you after the event. If you do have any questions in the webinar, feel free to email us at info@drcare.ca. You can do it now or after the event, and we will do our best to get back to all questions. So the purpose of today's program is to provide you with an overview of the longitudinal family physician payment model, also known in short as the LFP payment model. Here's what we will cover today. We'll start with an overview of the new payment model, including the main highlights and benefits for physicians. We'll go through the initial and ongoing eligibility requirements and the required services once you have enrolled. Then we'll move on to compensation. We'll talk about 3 ways in which you get paid under this new model. We'll also walk you through on how to enroll in this new model. And lastly, we'll go through how we can help you get started with a promotion exclusive to all webinar attendees today. To start, let's go through an overview of the new payment model. So effective February 1st, or tomorrow, the ministry has announced an LFP payment model, which is a blended payment model for family physicians who provide longitudinal relationship-based family medicine services to known panel of patients. The main highlights of this model include compensation to address rising business costs, equitable funding that encompasses all of a physician's work, and recognition of the value of physicians who provide longitudinal care. There'll be compensation for the time spent on clinical administrative tasks and indirect patient care. There'll be compensation for time spent with patients, number of patient encounters, and the panel size and the complexity of those panel patients. And you'll continue to have business autonomy for physicians, giving you flexibility to create the kind of practice that works best for both yourself and your patients. By switching to this new model, what we've seen through the payment calculator and speaking with physicians is there's an approximate increase in revenue of about 40%. Again, this is on a case-by-case basis and may change physician to physician, but that's the average we've been seeing across the board. So for a physician to be eligible for compensation through the new model, they must satisfy the following initial eligibility requirements. So you must commit to provide all required services. And this is actually quite a long list, so we'll go through that in the next couple slides. You have to contribute to the rent, lease, or other operating costs, either directly or indirectly, of the clinic that you'll be signed up for in the LFP model. And then in the future, you'll have to not withdraw from the LFP model within the previous 12 months and like I said, this year, that's not really an issue. With that being said, the Medical Service Commission could provide written approval that the physician is eligible to re-enroll. And lastly, you must not be deemed ineligible by the Medical Service Commission unless the same Medical Service Commission provides written approval that the physician is eligible to enroll. So that's the initial criteria. There's also ongoing criteria. So if you meet the initial, every year you have to meet that. Every year as well, you'll have to submit the registration code to Health Insurance BC via the teleplan between Jan 1st and March 31st of every year to confirm that you still meet that initial criteria. And on a yearly basis, you'll also have to confirm your panel of active patients. So as I mentioned before, there's quite a bit that goes into required services in this new model. So first off, you must provide community longitudinal family physician services. Secondly, you are required to develop and submit an accurate list of active patients for whom they have accepted responsibility by July 1st or within July 1st, 2023 of this year, or within 3 months of enrolling in the LFP payment model, whichever is later on a yearly basis. 3, you must provide timely, accessible, comprehensive, and relationship-based care to patients by working and collaborating with other physicians and healthcare providers when appropriate. 4th, you must provide LFP practice services to a known panel of patients. And this panel of patients must be at least 250 active patients, and you must be working a minimum of 1 day per week for this panel of patients. This must be distributed equitably over the course of the year. We really want to drive this home that you need a panel of 250 active patients from the time you enroll in this LFP funding model, not that you have already signed up and are planning to grow your practice, but it's already at that size. 5th, a maximum of 30% of your services are allowed to be provided for patients not on your panel. So for walk-in patients, you can provide up to 30% of your services. Patients that are seen in your clinic don't contribute to that 30%. It's only walk-in, non-regular patients at your practice. Continuing with just a few more. So 6, you need to be able to provide patient care consistent with any interim or permanent guidance on the appropriate use of virtual care. So of course, then we'll see what changes may occur there. 7, you have to encourage patients to participate in a provincially administered primary care survey. 8, you have to create and maintain adequate medical records. So I'm sure plenty of you are already completing this. And lastly, you must agree to Audit and Assessment Authority of Medical Services Commission as set out in the Medicare Protection Act. So if you meet, all of these required services as well as the initial eligibility that we spoke about, then you are eligible for the new LFP payment model. And we'll walk through later how you can actually get signed up for the new payment model if you're not already. So if you move to this new payment model, there are some codes that are still eligible in this LFP payment model, and there's also some codes that are no longer eligible. So the codes on the left, like obstetric delivery incentive and unassigned inpatient care fee, can still be billed under the new payment model. But then the codes on the right that we see there, inpatient hospital care, in-hospital maternity care, that kind of stuff, you can still bill for these codes, but you won't be billing them under the LFP model. You'll actually be billing them under the fee-for-service model. So different schedule of benefits there, different list of codes. You'll bill them as you do today. So no changes for those services on the right there. And just to note, because we mentioned it before, that up to 30% of your services can be to non-panel patients. These claims aren't included in that 30%. This is outside of the LFP model. In addition, no direct or indirect times, so none of the time codes that we'll get into can be billed for WorkSafe BC, ICBC, or out-of-province patients. You will continue to bill for ICBC and WorkSafe BC and your uninsured services in the same way that you do now. However, you can bill the non-WorkSafe BC or ICBC portion of your visit as an interaction code, which we'll go through. We'll go through those codes in just a bit. Now, some codes actually are ineligible, meaning you can no longer bill for these. And as family physicians, one of the main ones that we're seeing is the chronic disease management codes, right? So you'll no longer be able to bill for those on a yearly basis. Same with the complex care planning and management, palliative care planning, and the rest of the list that we're seeing here. So some codes are no longer eligible in the LFP model. So this is important to note. We know that some doctors are largely focused on chronic disease management billings, and that might make up a large portion of your income. So it's always great to just assess first if it's beneficial for you to switch this new payment model. And again, if you do decide to switch to this new payment model for this year, you can submit your CDM billings. You have to do so before switching to the LFP payment model. And then, of course, moving forward, you'll no longer be eligible for those bills. If you do have any questions on who those patients might be, or if this is the right, how much of your income does it make up for, please feel free to reach out as I mentioned before, and we'd be happy to run an assessment for you. So there are some limitations. So physicians can bill under the LFP payment model if physicians are either on their panel, patients are either on their panel or the panel of physician at their clinic. But patient care provided by non-physicians, so nurses, nurse practitioner, allied care professionals, those are not billable under the LFP payment model. So you cannot bill for it if a nurse practitioner is seeing your patients for you. So getting into the compensation part of things, physicians are now compensated through 3 categories, and we will go through in detail each of these categories. So you'll start to get paid for your time. You'll be paid for patient interactions, and you'll also be paid for your panel. So just to go through each of these, right? So payment for time, a physician may claim for their time work daily using time codes for direct patient care, indirect patient care, and clinical administration. So to clarify these terms a bit, direct patient care is the time spent providing the following clinic-based services with the patient present, right? So this includes things like in-person care, right? And that includes home visits, synchronous virtual care, so phone calls and video calls, as well as clinical teaching, right? So we're working with med students or residents and seeing patients with them. You can bill for those interactions. Indirect patient care, right, is time spent providing patient-specific services when the patient is not present. So these kind of things are charting and documentation, reviewing of labs, chart review, those kind of things that I'm sure you do a lot of that on a daily basis. And then the third type of payment that we spoke about is clinical administration. So these are activities that may not be patient-specific, but require the professional expertise of a physician for management of the patient panel and practice. So think, panel management, review of your panel, updating your EMR, making sure that's up to date. So a lot of that administrative tasks that historically there was no payment for, you're doing that in your spare time. Now you can bill for your time there. There is a bit more detail that you see in the payment schedule. So if you're looking for the real weeds of it, the payment schedule has a bit more to it. But this is the 3 types of time payment. So there are some limitations to time payment. So only 1 time code at a time is payable, right? So start and end times cannot overlap for different payment types, right? So if you're billing from 2 to 3 o'clock direct patient care, that means you can't bill from 2:30 to 3:30 in direct patient care because those times would then overlap. So of course you can only be doing 1 kind of time at a time. And then there are certain limits there, right? So the maximum amount of time payable is 14 hours in a single calendar day. And the maximum amount of time payable is 120 in 14-day period. So there's single day and also 2-week restrictions there. And the maximum amount of time billable as clinical administration is 10% of the total amount of time claimed by the physician in the calendar year for all 3 categories, for direct patient care, indirect patient care, and clinical administration. So the thought there is if you spend, 100 hours doing direct patient care, indirect patient care, and clinical administration, up to 10% of that 100 hours is billable for clinical administration. So 10% of 100 is up to 10 hours of time can be for clinical administration. With that being said, it is anticipated that clinical administration will take up in the range of about 5% of the time claimed under these time codes. So we don't really expect that being a big issue. To claim time codes, you would need to submit the total number of units on the first patient of the day using their personal health information and demographic information. Time codes are billed in 15-minute increments. A physician must work the full 15 minutes to bill for that 15-minute increment, right? So if you're working for 35 minutes of direct patient care, you're only entitled to 2 units of that direct patient care bill, which we'll go through what that bill is in a second. That extra 5 minutes would be lost there. The following fields on the slide are required for each time code submitted to Health Insurance BC. And then one thing to highlight here is this diagnostic code L23. That will always be the diagnostic code for time codes. And then we'll also go through what the service codes are as well. So these are the three time codes that we've been speaking about: 98010, 98011, 98012. For details and requirement on the specific codes, as mentioned before, the real weeds of it, you can look through the LFP payment schedule, but we'll go through them at a higher level. And then one thing to reiterate, though, is that these codes are only available to physicians who have first submitted the registration code, the 98,000 registration code. You can't submit this if you're still in the fee-for-service model. So let's go through an example. We see Dr. Smith here start seeing patients from 9 a.m. to 12 p.m. His first patient is Jane Doe at 12. And then at 12 p.m., he stops seeing patients and spends time completing patient documentation. So charting and whatnot with different patients and reviewing lab results. He does that for an hour. And at 1 p.m., he starts again seeing patients for the next 3 hours until 4 p.m. And then the name of that first patient in the second block is James Johnson, right? So you saw Jane Doe at 9, you saw James Johnson at 1 with an hour of indirect patient care in the middle. So how would we go about billing this? And I'll give a second so people can think about it. So as we mentioned, you do not bill the time codes for each individual patient if you're doing a block of work. You would just need to bill that total number of 15-minute units of time providing patient care under each time code of the whole day. So there's actually two ways you can submit for these codes, right? So first you can bill under the first patient, which is Jane Doe, for 12 units being 3 hours, right? So you bill at 98010 for 12 units. And then you bill 4 units of indirect patient care, 4 units being 1 hour of 98011 indirect patient care. And then again, you bill for another 12 units under James Johnson for direct patient care. And that 12 units is 3 hours, and that's 98010 again, right? So you can break up the codes into your separate parts of the day. What we've also seen is because it's quite natural to do direct and indirect patient care throughout the day. So rather than going back and forth between the codes, you can actually just lump them together. And you can bill all 7 hours or 28 units under Jane Doe, so your first patient of the day, and bill it all as direct patient care. And that's because it's understood that you go between direct and indirect patient care throughout the day, so that you can just lump that all into one big payment. So that's for time-based codes. Moving forward, physicians can also bill for their physician-patient interactions that are included in the LFP payment model using a patient interaction code. Please note that fee-for-service codes, such as tray fees, diagnostic tests, are now not payable in addition to the patient interaction code. Rather, there are new fee codes that the ministry's introduced that you'll be able to bill to cover those procedures, but you don't bill what you used to bill in the fee-for-service model. Now, the patient encounters can be, either in person, by the phone, or video, using the correct interaction codes, which we'll go through in a second. So there are some limitations. The maximum number of patient interaction codes in a single calendar day is 50. So there's a limit of how many patient interactions you should be having. And this maximum applies to all patient codes except for one, the 98022, which we'll go through in one slide what that means. And then again, as we mentioned earlier on, a physician cannot claim more than 30% of their patient interaction codes for non-panel patients in one calendar year. So the physician is not entitled to payment in excess of that 30% limit. If a physician does exceed the 30% limit, they cannot bill for additional clinic-based services for those patients, for those non-panel patients. So how to bill for these codes? Here's the list of what needs to be filled out for each of these claims. It's pretty similar to what you'll be doing today. It shouldn't change too much. The codes are different. The codes that you'll be billing are slightly different, but beyond that, it's pretty similar to what you'd see today in your current model. So what are these new patient interaction codes, right? So the ministry's been able to really whittle it down to just 8 codes that you'll be billing on a day-to-day basis. So you'll see codes for in-person interaction, right? The 98031. You'll see virtual or phone 98032, and a bunch of other codes here. There's a lot of detail around this in the LFP payment schedule. But what we did want to highlight here is that all codes except for the 98022 are standalone codes, meaning you can't bill for an in-person interaction in a clinic and a in-person interaction with a standard procedure. You can't be billing both of those together. You're going to want to bill for the higher of the two codes that it makes sense for you to claim. So like I said, between those two codes, if you're doing a standard procedure and an in-person interaction, you'll just bill the 98021 because that pays out at $60. You won't also bill the 98031 on top of that. As for the last code, the 98022, that's the LFP minor procedure or diagnostic test provided with an in-person interaction. So this is billed as an add-on code. So you bill this alongside one of the other in-person interaction codes. Of course, you can't bill it with a virtual code, but you can with one of the other in-person interaction codes. So just to go into a bit more detail about that, because that's the one nuance code, is the LFP minor procedure diagnostic test, the 98022, is payable at $10, of course, plus the time and the interaction code you bill it with. So you can bill this code in addition to the 98020, the 021, 030, 031, and 033, just not the virtual code that I mentioned before. You can bill up to a maximum of 2 of the services from the list on the slide here on the right side of services there. You can bill up to 2 for a patient visit. And then only 1 of each type of minor procedure diagnostic code is payable per day per patient. Right, so if a patient comes in and you do cryotherapy and a urinalysis and a pregnancy test, for example, you try and do all 3, you can only still bill 2 units of the 98022. You can't bill for that 3rd unit of it. It's up to 2 units per day. And then you'll also bill alongside that 98022 an interaction code. So just to give an example here of how to use all these codes together, right? So an active patient comes in to see you to get an IUD insertion, and you complete a pregnancy test as well as doing the IUD insertion for the patient. So in addition to your time code, so let's leave the time code separate here, what interaction codes would you build for this? So just to give a second to think about that. So like I said, we're not going to talk about the time codes right now, just the interaction codes. So since you're providing a pregnancy test, that allows you to build that 98022, the LFP minor procedure diagnostic test. And on top of that, since you did an IUD insertion, you're allowed to build that 98020, which is the major visit with the interaction, the major procedure with that interaction. So between the two, you build both those together at $120. And as a reminder, again, that's not including the time-based code. So if you also spend half an hour with the patient, you build 2 units of time alongside. So that's billing. It's really simplified. There's a few codes. There's only 1 add-on code to bill now, and you just have to choose the right code between all of those codes. So that's the interaction codes. Moving on to the panel payments, the 3rd way you get paid in this model, right? In addition to the payment of time and encounters that we've gone through, physicians are also paid for their panel. A panel payment is a payment based on the number of active patients a physician has and the complexity of those patients. So you get paid higher or lower based on patient complexity. For 2023, so far for this year, the panel payment will be using the CLFP methodology, but we do expect a new calculation for panel patients to be released over the year, and we'll be able to provide more insights into that when it is. So now we've gone through all 3 payment methods. I'm sure a lot of you are excited potentially to join this or might have questions if it's the right thing for you. So just to walk through quickly how to enroll into this new LFP payment model, you need to submit the registration code 98,000 to Health Insurance BC to switch to this new model. To do so, you actually have to make a specific patient, right? So with demographic information of a specific PHN, specific first and last name, date of birth. And like I mentioned before, this ICD-9 code L23 is the same one you use for your time codes. So you'll use that specific time diagnostic code alongside the 98,000 registration code. In essence, this payment model does not require a contract. Physicians just need to bill a portal code, kind of similar for those of you who signed up for the 14070 portal code that was built a few years ago. And that will let you switch to this new model. Once you've enrolled, it is recommended you hold your bills back for about 5 business days. The reason for that is the system just needs a bit of time to update you into the new payment model. So we do recommend holding your bills for 5 business days and submitting after that. Bills and payments are the same as they were before through MSP or teleplan, so the rest of it stays status quo in that way. So to get a bit more into the registration code, since this will be the first year that physicians will be enrolling in the new payment model, they can submit the code anytime after February 1st. However, after the first year, the code must be submitted once per calendar year per physician between Jan 1st and March 31st. If you do not submit your code by March 31st, no subsequent payments will be paid under the payment model until the code is submitted, the 98,000 enrollment code. By submitting the 98,000 code, the physician can only claim for payment in relation to services in accordance with the LFP. So those specific interaction codes that we spoke about, you can no longer bill a lot of fee-for-service codes or CDM billing codes that you used to bill for. You can only bill for those LFP to your panel patients. So submission provides access to LFP panel payment and all the codes under the payment model until the end of the calendar year. And then again, like we said, you re-sign up for that in Jan 1st if you so choose. We've heard that there's potential of some registration codes issue, right? So we do have a few steps that you can follow in order to try and mitigate that. The first one that we see or are expecting to see is that the ICD-9 code L23 may not be in your EMR yet. So since your EMR may not be able to recognize it, it is great to reach out to your EMR provider to try and get that updated. But it's also recommended to submit the code 780. If that still doesn't work, we do again recommend contacting your EMR vendor. Feel free to reach out to us as well. We're happy to walk you through that process and any issues that might be occurring. And worst comes to worst, last case, you can try and contact Health Insurance BC if the EMR vendor is not helpful there. But most likely you should have it resolved by then. So what are the next steps and how do you prepare for these new changes? Things that you can do now, right? There's a few things that you need to confirm, like your MSP facility number. Most of you probably have that already, but just to confirm. Just to review guidance on the group governance agreement, and we'll share a link to that in the chat. Watch out for any upcoming changes from BC Family Doctors and Doctors of BC websites. They're constantly updating that. We're also keeping an eye out and we'll be sending out monthly newsletters. So if you have any interest in signing up for our newsletters, we'll be provided a link to that as well, where we'll be providing any changes that you might see or expect to see. So here's an upcoming timeline of what to expect in the following months, right? So February 1st, tomorrow, the new payment model goes into effect. So for those of you signed up already, you'll be billing differently as of tomorrow. Shortly after the payment model, right, comes into effect, we expect to see information on how locums can bill under this payment model. And again, we'll be sending out communication on that once we hear more about it. By July 1st, you're expected to be able to submit your panel, and there'll be more details surrounding that on how to submit that. And then by mid-year, the ministry will work on expanding the model to maternity, in hospital, and long-term care as well. So we know that changes can be very overwhelming, and we're here to help in any way we can. So if you'd like timely updates to all changes, we highly suggest subscribing to our newsletter. We always will send those out as soon as we hear them. We share the latest changes and resources to billing related subjects. And again, we've entered that link in the chat box, and we'll also share it in a follow-up email with the webinar recording. So the big question, right, is this right for you? Should you be switching to this new payment model? And it's not always as simple as a yes or no. So if you're looking for any help in evaluating if it makes sense for you, please reach out to us. we'll leave our email on how you can reach us, so that we can do a practice assessment for you, check how much you make in your current model, what the expected is in this new model, and does it make sense to switch. And if you do decide to switch, we're happy to walk you through that process, how to submit the code, making sure all your paperwork's in the right place. And lastly, of course, ongoing maintenance, right? Making sure your panel's up to date, making sure your billings are correct, making sure you're in all the right guidelines of 30% of your panel payments, patients, and all of that. So please don't hesitate to reach out. As I said, we do have our email here, info@doctorcare.ca. Please feel free to reach out. We are reaching the end of our webinar, so if there were any questions or if you have any feedback for us or any clarity you need, please let us know. You can reach us info@doctorcare.ca. And as I mentioned, for all webinar attendees, we'll be happy to run a practice assessment to make sure it makes sense for you to switch to the new model or stay in your current. Otherwise, I hope everyone enjoyed the webinar and have a great day.